Good morning and welcome to today's webinar, Making Connections, the Critical Role of Family-Centered Care in Addressing Social Determinants of Health for Children and Youth with Special Healthcare Needs. This webinar is the first installment of the National Resource Center for Patient Family-Centered Medical Home, or NRC, Annual Education Series. Next slide, please. My name is Tom Scholes, and I'm pleased to serve as the moderator today for this webinar. I'm a professor of pediatrics in the Stead Family Department of Pediatrics at the University of Iowa, where I've been on faculty for nearly 27 years. I'm a pediatric cardiologist, and I'm currently acting as the director of the Division of Child and Community Health in the Department of Pediatrics. And I serve as the director of Iowa's Title V Block Grant for Children and Youth with Special Health Care Needs. This program oversees 14 regional centers in mostly rural areas across Iowa that provide services and supports for children and youth with special health care needs and their families. I'm also a member of the NRC's Advisory Committee, and I'm looking forward to being your moderator today. Next slide, please. This webinar series is presented by the NRC in partnership with the Bright Futures National Center and the Screening Technical Assistance and Resource, or STAR Center. The NRC, Bright Futures National Center, and STAR Centers are all grant-funded programs of the American Academy of Pediatrics. The goal of the NRC is to improve the health and well-being of and strengthen systems of care for children and youth with special health care needs and their families by providing technical assistance and supporting implementation of the medical home model. The goal of the Bright Futures National Center is to promote and improve the health, education, and well-being of infants, children, adolescents, families, and communities. The goal of the STAR Center is to provide evidence-informed resources and individualized technical assistance to improve the health, wellness, and development of children through practice and system-based interventions in order to increase rates of early childhood screening, counseling, referral, and follow-up for social determinants of health, maternal depression, and child development. Next slide, please. The NRC and Bright Futures National Center are cooperative agreements between the American Academy of Pediatrics and the Maternal and Child Health Bureau. This slide includes the funding attributions for the NRC and the Bright Futures National Center. The STAR Center is promoted through funding from the JBP Foundation. Next slide, please. This slide presents disclosures, and Dr. Altrow has some funding disclosures that are listed here. Before our faculty begin, I'd like to inform you of some housekeeping items. The slides will appear on your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the chat box on the right-hand side of the screen. These questions will be answered at the end of the presentation. If we do not have time to answer all your questions during the webinar, we'll send you an answer directly via email at a later time. And this webinar will be recorded and archived on the NRC website approximately 1 week after this presentation. After the webinar, you will receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. Next slide, please. The webinar series has several learning objectives that are listed here. First, it will be to describe data trends related to the impacts of social determinants of health on children and youth with special health care needs. Second will be to discuss the role of the medical home model in addressing social determinants of health for children and youth with special health care needs at the state, community, and clinical levels. And third, to identify practical, replicable strategies being implemented by state Title V programs, families, and primary care pediatricians to address social determinants of health for children and youth with special health care needs by using components of the medical home model. Next slide, please. Before I introduce our guest faculty, I'd like to mention the various social determinants of health resources available for participants from the NRC, Bright Futures, and the STAR Center. These resources support pediatricians, state Title V programs, and families to address social determinants of health at the clinic, community, and systems levels. We encourage all participants to review these resources. Next slide, please. And now I'm honored to introduce you to today's speaker, Dr. Amy Hautrow. Dr. Hautrow is a professor and endowed chair in the Department of Physical Medicine and Rehabilitation and Pediatrics at the University of Pittsburgh and the UPMC Children's Hospital of Pittsburgh, where she serves as the division chief of Pediatric Rehabilitation Medicine, the vice chair of Quality and Outcomes, and the medical director of the Rehabilitation Institute. She is a health services researcher for children with disabilities and studies how children with disabilities and their families interact with the healthcare system to identify opportunities to improve access to care and optimize the health, functioning, and well-being of children with disabilities. I now turn the floor over to Dr. Hautrow.
Thank you very much for that lovely introduction, and it is my pleasure to be here today. But I actually have an alternative title for this presentation. We've got a lot of work to do, people. So this series is in two parts, and I am giving you a piece of the objectives here as our goals for the next 40 minutes. We'll talk about the basic trends in the social determinants of health for all children, and then we'll spend time thinking about them and the impact of the social determinants of health on children and youth with special health care needs. We'll review access to the medical home and family-centered care for children and youth with special health care needs, and we will, at the end of the talk, increase our understanding of how the medical home model can play a role in addressing social determinants of health for children and youth with special health care needs. Just to do some stage setting, I'm going to provide you with some definitions. This is only to make sure we're all on the same page. We'll start out by defining the population of interest. I am going to define for you health, and you might think that's a little odd because all of us probably have a definition of health. So I want you to think about what definition you have as we go through the definition that I provide. And that will lead us into talking about social determinants of health, health equity, and this just to make sure we're on the same page, I'll define the medical home and family-centered care. So imagine this, all children in the United States. A subset of these children are children who have special health care needs, and they are defined as children who have chronic health conditions and who also require health and related services of an amount or type that is required beyond generally for all children. And this definition comes to us from a 1998 paper. You'll see that citation below. And currently, there are about 13.6 million children in the United States who have special health care needs, or 18.5% of the child population. But what I want to point out to you is now we've divided this group into children with special health care needs and those without. But in the definition is the issue of risk of developing a chronic health condition. And we have to understand that especially for children who are impacted by the social determinants of health, their risks are higher to move from the dark blue to the turquoise. Within the group of children with special health care needs, there are children who are affected in their everyday lives by their health conditions. And these are children with disabilities. They make up about 8% of all children, depending on the definition that you use. And within that group is an even smaller group of children with medical complexity. These children have very complex healthcare conditions. They require and need a lot of services, and they make up about 1%. We often hear about this because they're a high-cost group, but they don't look like the rest of children with special health care needs, whose needs are really diverse. And so I want us to kind of think of this schema as we go through the presentation and focusing on the larger group of children and youth with special health care needs. So I told you I would define health, and I'm taking the definition from the Institute of Medicine report, Children's Health, the Nation's Wealth. And this came out in 2004. I was in training and it really resonated with me, and I hope it resonates with you. So children's health is the extent to which a child or group of children are able to develop and realize their potential. As pediatric healthcare providers, this is our wheelhouse. Satisfy their needs. I want you to hold this in your brain because we're going to get to this again, and develop the capacities that allow them to interact successfully with their biological, physical, and social environment. This same report provided a model for us to think about health. So if child's health is in the center, over time and across development, there are multitudes of factors that interplay to affect health outcomes. They include the social environment and the physical environment. And this is what we're talking about when we think of the social determinants of health. Very broadly speaking, these are the conditions in which people are born into: live, learn, play, work, and grow up. And we can be thinking of them on multiple different levels. So for example, interpersonal level factor, your teacher from 4th grade maybe really shaped your future. And these are the kind of things that can impact us going forward. Obviously, there are health system factors, access to care, the quality of care that is provided. And for children who live in more rural areas, we know that they have less access. And within society, there's a whole bunch of cultural and policy-related factors such as stigma, racism, and discrimination. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. And that is an outcome. That fair and just opportunity to be as healthy as possible is an outcome. And it requires a process. That process is removing obstacles to good health, such as poverty, discrimination, and all of their consequences, including a lack of access to good jobs, fair pay, quality education, housing, safe environments, and for us, healthcare. So I want you to think of a child on the river of life. And this is how I'm going to frame for you the social determinants of health. There are some things that really help guide us. So our parents having good jobs and fair pay, stable housing, safe environments, give us a smooth river to flow on. Quality education sets us up for success in the future. But there are other things, negative things, such as poverty and discrimination, that make the river journey very bumpy, and they can have negative consequences to our health. And much of what we do in healthcare actually is down here after dealing with the impacts of poverty and discrimination and their consequences on health. And what I want us to be thinking about, and we think about the medical home intervening, is not only after health has gotten bad or poor, but earlier. And as pediatric healthcare providers, this is our wheelhouse. We know about the importance of engaging early and doing preventative care. So those of you in the audience who have a psychology background or are social workers, you might be quite familiar with this. I gave you a definition of child health, and in that definition, I asked you to remember, satisfy their needs. And so on these two bottom parts of the pyramid, that's what we're talking about. The very basic, satisfying their physiologic needs, water, food, shelter, and their safety needs, living in safe environments, having access to healthcare when they need it. These are the foundation of what allow children to grow up and to have successful lives. We want, as pediatric healthcare providers, for all children to self-actualize, to be the most that they can be. But we have to focus on these bottom parts of the pyramid because this is where the social determinants of health come in. I promised just to do a stage setting. I'm defining the medical home, but I think most of us understand what that is. Not a building or a place, but an approach to comprehensive primary care. And the Maternal and Child Health Bureau says we can measure it through these metrics of having a personal doctor or nurse, a usual source for care, family-centered care, no problems with referrals if they are needed, which is common for children with special healthcare needs to need referrals, and care coordination if you need it. Family-centered care is an approach to planning and delivery of care that is really grounded in mutually beneficial partnerships between the patients and their families and healthcare providers. It's all about honoring the strengths and expertise, the cultures, traditions that all members bring to the table. And family-centered care is a piece of the medical home model. The Maternal and Child Health Bureau say we can measure this by whether or not the provider spends enough time, listens carefully, is sensitive to values, gives needed information, and makes the family feel like a partner in care. The Maternal and Child Health Bureau has a set of system goals for children with special health care needs, and they do include family partnerships and access to the medical home, as well as community-based services, screening, successful transition to adulthood, and adequate health insurance. So when you're thinking about the medical home, I want to expand you a little bit to think about the health neighborhood. So I am from Pittsburgh, home of Mr. Rogers' neighborhood, so I thought it was fitting to do this here. So I want you to imagine a child living in this house. It's a nice house, there's sidewalks, it's clean, and it's safe. And this child can go to a pediatrician right nearby, and that pediatric office has family-centered care and provides care in a medical home. And if something catastrophic were to happen, there is a quaternary care top 10 children's hospital right nearby. Additionally, the child can go to school in this really great school where kids are successful in achieving their goals educationally. All of these pieces, the environment in which this child lives, their access to needed services and education, make it possible for this child to have great health outcomes. But what about the child? And in addition, we have this great public transportation, which doesn't exist for this child who lives back here in rural areas. They don't have the same access to all these things. Or what if a child lives nearby this burned out building, which is still polluting the surrounding area? And it turns out not all neighborhoods are the same. Mr. Rogers' neighborhood extended past the picture I just showed you. This is that same child's house we were talking about. But what if further away, there was a child living in poverty? That child is living in a trailer park. They don't have a car. And so their opportunities for health equity are much different. So to achieve health equity, we talked about discrimination and poverty. So for discrimination, we're talking about all sorts of discrimination, from discrimination related to race, to gender identity, sexuality, disability status, religion, all sorts of things. But today we're going to focus as it relates to discrimination against Black and brown people. And what you're going to see me do through this talk is give a shorthand where I show you data by race. And when I'm showing you data by race, I'm not making a claim that there is anything biologically, genetically different between the races that is to explain the differences in health outcomes. It's not that at all. It's shorthand for understanding the structural discrimination that is built into our society, the impacts of personally mediated racism, and the impacts of internalized racism. So it's a shorthand, and we're only doing it for racial discrimination, but I want you to remember that there's many other types of discrimination as well. And on that topic, I wanted to point you guys to two important articles. This one, The Impact on Racism in Child and Adolescent Health, was just published last year by Dr. Trent and colleagues. And if you have any questions about how impactful racism is on child health, this is a great resource to look at. The other one is written about 10 years ago, Social Inequalities and Racial Discrimination, which lead us to health disparities for children with color, really help organize our thinking in the relationship between poverty and race. And I just want to show you this really quickly. It's the way in which racism can affect health. So there's exposure to various types of racial discrimination. That can be on the macro level, such as the structural ways that racism is mediated in our society, or it can be on the personal micro level, so such as being bullied or teased because of your race. All of these have psychological and physiological consequences, such as increased allostatic load, cortisol levels, blood pressure problems, and all of these are associated with poor health outcomes and health disparities. And so now to move us to poverty. In 2018, 16% of all children lived below the federal poverty level. This year, that level is $26,000 a year for a family of 4. And this accounts for about 12 million children. And I would be remiss not to note right now that things are probably much worse. We're in the middle of a pandemic where many people have lost their jobs, and it has been disproportionately impacting those who live in or near poverty and those who are minorities. The other thing that's important to understand is even if you live above the federal poverty level, it does not mean that you actually have what you need to support your family. So in fact, approximately 43% of children live in families that their income isn't enough. So I did a budget calculator example for you. So this is from the National Center for Children in Poverty. And basically all you have to do is put in where you live and the family. So I picked Washington, D.C., a single mom with 2 young children. And the calculator then gives me the average amount for rent and utilities, food and childcare, and totals it all up. And what it shows us is that you need $72,000 if you're this family living in Washington, D.C. That is an hourly wage of $35 an hour. You're not making that at a full-time job at McDonald's. You're not making that at a full-time job at McDonald's and Burger King. You're not making that if you have 3 full-time jobs, McDonald's, Burger King, and Wendy's. So what we have here is a problem with people even being able to meet the basic needs for their families. So I told you that discrimination and poverty go together, and this is an excellent example of this. This is over time, the last 10 years. So over here you see 2009, and we finish at 2018. These are trends by race and poverty. You can see here that we've done better because it's been downward sloping, and that's due to the Great Recession. And of course, if we had measurements today, it would be up here. But the key thing I want you to note is that we have this group of children here, children who are minorities, and these are white children. White children, only 11% of them live in poverty, compared to 26% of Hispanic children, 31% of Native children, and 32% of Black children. And this slide, to me, is stark and makes me a little bit tearful. These are children who live in families who have less than 50% of the federal poverty level. These are families who are past the brink, and they're in crisis. They make up 5% of white children, 10% of Hispanic children, 15% of Native children, and 16% of Black children. What's going on here? We have families who can't get good jobs with fair pay. And so this is, over time, the percentage of children whose parents lack secure employment. And that's 27% of children. No wonder so many of them are living in poverty. And when you don't have a good job with fair pay, you end up being food insecure. This is the same trend over time. 17% of children are food insecure. I do not need to tell you the importance of good nutrition for the development of a healthy brain and a healthy body. In addition, there's a major problem with stable housing. This is a metric that measures the cost of housing in relationship to income, and housing becomes really unstable when you're spending so much of your income on housing. And in fact, renters who live in poverty spend 63% of their income on rent. That leaves so little money to pay for other things. So this is why we see such problems with food insecurity, and we also see lots of transitional housing problems. I don't need to tell you that homelessness is bad for health, and it certainly is. So out of all of the homeless Americans, 1 in 5 of them are children. And when you think of homelessness, you might think, living under the bridge or Skid Row. But for children and families, it's more couch surfing and high eviction rates. And when you get evicted, you also lose your stuff. And living in cars. And then you get a ticket from the police for living in your car, which you can't pay. So your poverty is being criminalized. And unfortunately, Among homeless children, half of them are Black. So let's talk about quality education, a real opportunity that we give our children to get out of poverty as they grow up. This next slide is, to me, the most shocking one I'm going to show you. This is the percentage of 8th graders who are below grade level for math. I've done this by race. The percentages are high. 57% of 8th graders who are white function below grade level for math. And it's in the 80s for Black children, Hispanic children, and Native children. We are not setting children up for success. We are not adequately teaching them the fundamentals in our education system. Additionally, we have a school to prison pipeline. So I'm just going to explain these slides to you really quickly. So this is the number of children expelled from school per 10,000 children. And it's not common, but it is really different by race. This is where the discrimination comes in. Twice as many Black children are expelled compared to white children. And where does that leave them? Oftentimes in juvenile detention. So this is per 100,000 children, 383 Black children per 100,000 are in juvenile detention. That's over 4.5 times as many Black youth in detention as white youth. And what's happening here? Schools have shifted. Behavioral problems, discipline problems are now thought as criminal problems. Budgets are cut, so nurses and counselors are not part of the budget anymore, but more resource officers are added. We move from being able to deal with behavior in positive ways to making it criminal and dealing with it in a negative way. And what about safe environments? Super important to well-being, obviously. So this is a measure from the National Survey of Children's Health by income, the percentage of children who they live in a safe neighborhood. So you're going to see a graph like this a lot, so I'm just going to orient you to the colors. So the darker green, these are children who live in the most well-to-do families. The less money you have, the lighter green the bar is. And these are children living in poverty. So what you can see is that the more money you have, the safer your neighborhood is. And what that means is the kids that need the safe neighborhoods aren't getting them. We can do the same measure by race, which I have done here. And as you can see, the white bar, these children here, have much higher rates of living in a safe neighborhood compared to Black children and Hispanic children. And I don't need to tell you about the impact of pollution on children or what it means not to have safe drinking water and have lead in the pipes, or what it means for children who have to do drills for active shooters. Or certainly this doesn't look safe for our immigrant children. So now I'm going to move to talk about children with special health care needs and the social determinants of health. The big ones we're talking about here are poverty and race, but we're talking about pediatric health care, so we're going to spend some time there as well. So children with special health care needs are more likely to be poor than their peers who do not have special health care needs. Again, this is that income gradient. The more money the family has, the darker the green. These are children living in poverty. And you can see this disproportionate impact, such that nearly half of all children and youth are poor or near poor, compared to 40% of other children. And what's going on here? We know we're having trouble with being able to have good jobs with fair pay, but families who have children with special health care needs have high rates of work loss, meaning they either have to cut back on work or stop work. And it's worse for some families than others. So this is a graphical representation of odds ratio. And we did this project where we looked at the odds of work loss among children with special health care needs based on certain characteristics. So each dot is the odds ratio and each line is the confidence interval. And this line indicates whether or not the actual number is statistically significant. So if the line crosses 1, it's not statistically different. And if it doesn't cross 1, it is. So if your child is limited, you're nearly 4 times more likely to have work loss. And if they're severely affected, it's 8 times. And if their healthcare changes a lot, there was not a difference for single parents, and there was just barely a difference for families living in near poverty. So now we're going to look at the issue of health slightly differently. We're doing this again by income, and this is families who have reported that their child is not in excellent or very good health. That I'm shorthanding to mean poor health. And about 10% of all children fall into that category, not excellent or very good health. And as you can see, there is an income gradient here again. The poorer children are more likely to have poor health. Similarly, they're more likely to be impacted by their health condition, so they're impacted in their daily activities. And about, in the National Survey of Children's Health, it's just under 11% of all children, but as you can see, it disproportionately impacts those children living in poverty. And it should come as no surprise to you that this also tracks in terms of racism and discrimination by race. So this is overall 18.5% of all children have special health care needs. 25% of Black children do. And Black children are more likely to be in poor health, and they are more likely to have disabilities. And this, of course, goes without saying. In order to benefit from high quality care, you need to be able to access that care. How are we doing there? This is receipt of family-centered care. Overall, we do relatively well. 87% are receiving family-centered care, and this income gradient that we see all the time is right here. So the kids who have the most trouble with social determinants of health, kids living in and near poverty, they're the least likely to have family-centered care. This is also true of Black and Hispanic families. They are less likely to have family-centered care. And as you recall, it's a key component of the medical home. So how are we doing there for children with special health care needs? Frankly, we are doing not well. Only 43% of children who have special health care needs are receiving care in a medical home. And I want to treat this like an opportunity. That means that we as pediatric health care providers can focus on getting these 57% of kids into medical homes. And of course, I'm going to show you this by race. And of course, it's different by race and by income. So this is income gradient, just as you would expect. The kids that need a medical home the most are the least likely to get it. And that is also true by race. So I wanted to present to you a relationship between health status and the medical home. So in this bar are children who are getting care in a medical home, and in this, they are not. As you can see, the purple, excellent and very good health. So this is much more of the column than it is over here. So children who are in a medical home are more likely to have reported very good or excellent health. This is not a causal statement because two things could be true. It's easier to provide a medical home for children who are healthier. Children who are healthier are more likely to be well-to-do, and we know we do a better job of getting more financially robust families medical homes. It could also be true that once we provide a medical home, we're providing better care, so the care leads you to be healthier. And it is likely that there's a bi-directional relationship here. But the point is that we've got to focus on these kids. And these kids are more likely to be minorities and are more likely to be poor. And I bet it feels like we're always trying to swim upstream. And in part it is, because what's happening here is we're dealing with the downstream impacts of the social determinants of health. And the big picture here is we need to figure out how to eliminate poverty, how to eliminate discrimination. And that is not something we're going to accomplish. We as pediatric healthcare providers are not doing that on our own. But I want to tell you that the work can be done and there's evidence that we can be successful. So a National Academy of Medicine report recently came out and gave guidance for reducing child poverty by 50% in a decade. And guess what, you guys? It can be done. We can convert the child independent care tax credit, increase, instead of decreasing SNAP, increase housing vouchers, and expand the earned income tax credit. And you're probably thinking to yourself, well, I bet that's expensive. And it sure is. The cost is a lot, almost $91 billion a year. But guess what? We know that investing early makes a difference. And it does. There's a payoff of nearly $93 billion a year. It's a worthwhile financial investment. And what about eliminating disparities? you're looking at this slide and you're thinking, why did she download such a bad copy of it? And it's because this was done in 1965. This is the UN saying we have ways to eliminate all forms of racial discrimination and we need to make it a priority. And one way that I looked into what has come forward into fruition are thinking about how communities can be in action. And this is a National Academy of Medicine report for Pathways to Health Equity. And they do make big, broad statements about what we need in terms of the policy milieu in which children grow up, including taxation reform, housing planning, that seems evident based on the data we just showed you, and obviously education, especially early education. And these things are near and dear to our hearts as pediatric healthcare providers, dealing with civil rights law and criminal justice reform, and ding, ding, ding for us, things related to health policy, especially focusing on prevention and early engagement. And that should make your pediatric healthcare provider heart go a-flutter. So this slide I borrowed from Neil Halfon, who is one of my mentors, and it's a graphical display of health development, how we reduce risk, and how we optimize protective factors. So for any child at birth, we want them to be on this very healthy trajectory. But we know that there are factors that influence it. There are things that push children down to an at-risk or disordered trajectory, including toxic stress, poverty, racism, discrimination, lack of access to health services. But we as healthcare providers know that there's a lot of things that we can do and emphasize, including early parental education and emotional health literacy, encouraging parents to read to their children, positive parenting techniques, giving and ensuring access to health services, and working with families to make sure that their children are in preschool. So I want to provide you another report from the National Academy of Medicine, Vibrant and Healthy Children. And really what they point to are things that really should resonate with us. So implementing across systems to support children and families, ensuring trauma-informed care, coordinating resources. And that's what a great medical home does, is figure out how to coordinate what the child needs in an organized way, and so it's integrated such that it meets that child's needs. They also had ideas about leveraging the healthcare system, such as things you might be doing in your medical home already, integrating behavioral health services with medical services, placing healthcare where communities are. You might be doing that through mobile health or telehealth, which is also one of their recommendations, addressing and confronting adversity that children are experiencing, and also things about diversifying our workforce and making sure our workforce are trained to understand the social determinants of health. So back to Mr. Rogers, this neighborhood looks great. Home. There is a guide from the CDC, the Health Equity Guide. I just pulled a few things that might be interesting to some of you. We all have different perspectives on what we really think that we can organize around, get excited about, or influence. So you might be somebody who is very interested in supporting breastfeeding, and that is something that your medical home could focus on. Or it might be about healthy food in schools, or making sure that families have access to food in their communities. Maybe you work with a local farm, they give you their ugly fruit, and you have a mini CSA for families that is of low cost or free right out of your medical home clinic. You may be somebody who's really interested in promoting physical fitness or violence prevention. There are so many opportunities for people in the medical home to really think about all the things they could be doing to really advance health equity. I don't think that we can tear down all of the structural things that negatively influence health for children, but I want us to feel empowered as pediatric healthcare providers that we can make a difference in our medical homes. We can influence these outcomes. I do have some practical advice for you, and the first one is making sure you're aware of your own role in perpetuating inequities. There might be processes that you have in your practice that do that. Signage that is only written in English may make people who don't speak English as their first language less welcome. That might not have been intentional, but it might be the consequence. We all have implicit unconscious biases, and we need to know that they might be informing how we deliver care, how we make decisions. Additionally, we may have set up our practice in such a way that we limit the number of children who are covered by Medicaid for financial reasons. And what that means is you're limiting access to the medical home to the children who would benefit from it the most. So it's really important as you're thinking about developing your health equity strategy in your medical home to be aware of your role in perpetuating inequities. And as a practice, it's really important that you come together with a shared vision around health equity and make that a clear value in your practice. It's also essential that when you're making your plans to develop strategies that engage your community. So this should not be something that you are laying upon people, but this should be something where you're really delivering and capitalizing on that family-centered care model, where what is needed in the community is understood from the people within that community. And you can make screening and addressing the social determinants of health a part of your practice. Very important then also to have resources available when you're doing that. So this is from Bright Futures, and this is a way to think about your screening. And what I want to point out to you is that not every risk factor has an associated or opposite strength and protective factor. And that's actually a good thing because it means that we can capitalize on these strengths. We can take opportunities where they are. So for families who have family household disruption, but they might have extended family that's really engaged and helpful, focusing on those connections can be protective. It's amplifying the strengths while working to mitigate the risks. And so I want you to feel empowered to start to think about how you and your practice, whatever type of practice it is, to be thinking about how you can start to address these, amplify the strengths, and try to minimize the risks. Because in healthcare, what we're doing is really working to promote children to the top of the Maslow hierarchy pyramid to self-actualize, be all that they can be. That's what we've dedicated our lives to. And as I am wrapping up, I do want to leave you with this quote from Dr. Martin Luther King: of all the forms of inequality and injustice, and it's healthcare that's the most shocking and inhumane. And I want to just give you some more graphics. So you probably have seen these cartoons. These were all over social media for a while. And while equality, this seems fair, it doesn't meet the needs of this child and isn't really helping this person. And so equity is that we meet people with what they need. So I really liked this. But in fact, I liked this one more. So I am a pediatric rehabilitation medicine physician, so I take care exclusively of children with disabilities. So having a ramp for this child to be able to see over the fence was really wonderful. And then, as people changed these, we got into reality. And when I showed you those slides about homelessness and living in extreme poverty and food insecurity, I do think it makes you realize that there are some members of our communities that have to dig themselves out of a hole. And it's not easy to do that because everything is pushing you down. And there are some members of our society for which there's a lot of advantage. Another way people have modified this is by saying, just take down the fence, liberate it. And for some of us, that might really resonate. It actually did not resonate so much with me. The reason is that I think there's a reason the fence was there. So that fence has a protective mechanism, which is why I really appreciate this. This is a replacement with an even better fence, better protection. And so when you're thinking about what you're doing as a pediatric healthcare provider, as we're remembering the process to get to health equity, it requires us breaking down the barriers. In our practices, in our communities, our pediatric healthcare providers, our colleagues, we can help replace that fence with a different type of protective fencing that does not discriminate against some children and gives everyone a fair and just opportunity for health. That health equity is the state in which everyone has an opportunity to reach their full health potential, and no one, no child, is disadvantaged from achieving this because of their social position or any other socially defined circumstance. Thank you.
Dr. Houtrow, thank you very much. That was a fabulous presentation. And you covered a lot of ground, and there are a lot of great questions coming into the chat box. So before we move on to take some of the audience questions, I first wanted to bring your attention to the numerous resources presented in this slide deck, as well as contact information. This slide deck will be made available to all attendees after the webinar, and a resource list will be disseminated to all registrants at the end of the webinar series. We have a few questions, as I mentioned, that have come in the chat box. The first question I was going to ask of you, Dr. Houtrow, was, what do you see as a way that Title V can partner with Medicaid to address social determinants of health in their states?
Well, I certainly hope you will help answer this question as well. So what we know about state Medicaids is there was a great opportunity with Medicaid expansion to really focus on this. There is a concept called adequate insurance. And basically what that means is the insurance meets the child's need to be able to get the services that they need, that the out-of-pocket costs are reasonable, and that insurance is continuous. And it turns out, especially for families who have children with disabilities, Medicaid does that very well. It's really for the families who are living on the edge of the financial line. For Medicaid, it can be a problem with continuation year over year. But for the families who are using a lot of services because their children have disabilities or other special health care needs, there's this great opportunity to actually be able to access services. So I think this marriage of thinking about what Title V programs are doing with what Medicaid can do in terms of providing adequate insurance is essential. And it's one of those key components that we have in the systems of care goals. And so to me, one of the things that the way we can marry more the Medicaid and Title V programs is really making sure that children who need that coverage aren't falling off of it, and that the types of services that they need are covered. A clear place where that happens very well with Medicaid is the continuous screening. So as we are obligated through Medicaid to do that, that gets us earlier identification of problems, which allows us to intervene earlier, which can improve long-term outcomes and is also cost-effective.
Well, and I would just add to that, because that's a great description of some of the to-do list. And I know engaging and working with our state Medicaid officials, just making them aware of the fact that there are pediatric issues, that there are inequities across the system that have a big impact on children. I think so often the Medicaid programs and Medicaid directors are focused on the big ticket items that are impacting adult medicine, and pediatric resources that they're having to allocate out of their budgets it turns to be just a small portion. So they tend not to think about those issues too often. And so I view our role as pediatricians and our role as advocates and our role as Title V leaders is to make sure we're engaging the Medicaid leadership so that they understand that there are opportunities. And going back to your early investment and the fact that you get this substantial, huge return on investment if you invest in children, just continuing to remind them of that, because so often I think their focus is on this year's budget and next year's budget and not the budget 10 years from now. And so the more we can do to remind them that there are these long-term impacts of the investments now, I think the better off we're going to be as far as what we can do to improve the health and safety of kids. So thanks.
I agree.
Another question came in about what would be what you think a first step to addressing social determinants of health at a population level that we may be able to take on as pediatricians in practice or leaders in different healthcare systems?
That's a really great question. And I think there's many different avenues in multiple different types of communities to do this. And I would encourage people to look a little deeper into what's happening in their communities, especially in relationship to qualified health centers. or if you live in a place where children are getting care in Indian health clinics for Native children, there's lots of great partnerships that are just right there for us to jump into and thinking about not just the patients that show up to our clinics, but the population of children in our communities. And I think all of us have a role of advocating not just for our individual patients' needs, but for all children's needs. And one of the first things that I think we can do is to highlight how pervasive and impactful social determinants of health are on child outcomes, and how we, as pediatric healthcare providers, know that we need to have healthcare transformation to do a better job so that we're not just dealing with the downstream impacts in our clinic, that we are part of and engaged in advocating for systems level change. And I do think that the Maternal and Child Health Bureau and the CDC and all of these organizations that function nationally want us to be engaged, and they want us to be engaged at each of those different levels. And so there are certainly ways that many of us would feel comfortable doing advocacy. That might be with our local representatives. It might be going to Congress. It could be letter writing. It could be writing an op-ed in your newspaper. But advocacy takes many forms. I think it's really important that we ground ourselves into the needs of the population of children in our communities, because one size doesn't fit all. And we want to be able to take strategies that have been demonstrated to work and then scale them up, elevate them, and potentially disseminate them, and have strategies to consider how we measure. So we need to know if things work. And one thing about the medical home is some of us are doing quite a lot of patient outcome tracking, and some of us are doing less of that. And so that's another opportunity to think about how we are identifying the risks associated with the social determinants of health, looking at the outcomes, and looking at how well our interventions were at addressing them.
Oh, very good, very good. It was a very comprehensive answer, and one that gets a lot of thoughtful ideas going. I think we'll take one last question. And I think for the providers in the audience, a question that I think comes up quite often is, what are the best strategies for primary care providers to actually identify the social needs and get referrals made for appropriate services, given the time constraints and perhaps even the lack of knowledge of community services that may be available?
So that's really an excellent point. And so obviously not everyone's practice has the same kind of workflows as other practices. Some medical homes, for example, have a robust infrastructure of social supports and social workers or behavioral health specialists who are already kind of gathering this information. But I want to take us back to something super fundamental. So family-centered care is about partnerships, and trusting relationships are a key point of family-centered care. And we know how to do this with our families. And so even if our screening is just in conversation, that's better than ignoring the possibility of these things being true. So my practice is all children with disabilities. I'm very lucky in my practice that I get to spend a little bit more time with families. I also get to know these families over the course of years. And recently in my clinic, I had a mom who just seemed a little bit off. She just wasn't engaged in the same way with me that I had experienced in all of our previous visits over the course of years. And because I already had a trusting relationship that she knew that I valued her, I was very comfortable in asking her, I feel like something's not quite right going on with you. I didn't have any idea what that was. So she looked at me and she took a deep breath and she said, well, we're about to get evicted and I don't know where we're going to live. So I happen to work in a healthcare system that has all sorts of resources that I can leverage, that I have instantaneous access to a social worker, that we have services that we can put on her plate almost immediately. But it took her trusting me to give me this information. One of the things that's really hard about the way our society is structured is we often demonize poverty and we make people feel like it's their fault. And so when we as pediatric healthcare providers can step back and help families understand that this isn't about blame. This isn't about you being a bad parent. And using our trusting family-centered relationship, we have these opportunities to help families. And so whether it's screening with a checklist that we have when we're talking to families, or something that they fill out in the waiting room, or if it's just utilizing what we know when we're engaging in families and taking cues from those children and families, there's lots of different ways. And I do think one thing to do is spend some time with Bright Futures recommendations in order to see how they're organizing the strengths and also the risk factors. And for practices that don't know much about what's out there in the communities, there are community partners who do. So it's finding that community partner, because what you want to be is the place that can help be a conduit. You don't have to provide all of the community resources yourself. You might provide some. You might be the place that hosts the farmers market on Saturdays for families. That'd be amazing, but that's not what's expected. It's about engaging. And so finding great community partners, and they will have ways to resource. That might be a children's hospital nearby. It might be a community organization, but it's about thinking about your workflow, thinking about what can be put into your workflow and how you will navigate that. The good news is you can do additional billing for providing more robust services. It doesn't always get reimbursed, but it's there for you, and we can continue to advocate with insurers to make sure that they pay for that. So I think there's a lot of opportunities, and it takes a hard look at your practice and your workflow and identify the right people. But I encourage you guys all to think about ways that even in the smallest way, you could change things so you're paying more attention to the social determinants of health and being ready to be active to try to address those issues.
Fabulous, fabulous answer. I think that idea resonates, that you don't have to do it all. You can be that safe space to start the process. So that is very, very wonderful. Thank you. And so I want to thank everyone for participating in the webinar, and thank you so much for your questions. And again, the time you took today to join us for this webinar. And thank you again, Dr. Houtrow. That was just an inspiring and wonderful presentation. We truly appreciate you taking your time and sharing your experiences and knowledge with all of us. And I think we're all going to be able to better support our kids and families with the information that you've provided. As previously mentioned, this webinar recording, slides, and unanswered questions will be archived about a week from today on the NRC website. Additionally, I will remind you that you'll receive an email after this webinar where we'll be asking you to take an evaluation. The evaluation only takes a few minutes, and we'd greatly appreciate your feedback. And this is the first installment of our 2020 webinar series entitled Making Connections, the Critical Role of Family-Centered Care in Addressing Social Determinants of Health for Children and Youth with Special Health Care Needs. The second webinar in the series will take place, as shown on the screen here, Tuesday, June 22nd, from 10 to 11 a.m. Central Time. We hope you all can join us for that next webinar. The registration information can be found on the NRC website. Thank you very much again for your participation today, and I hope you have a good rest of your day.